Hi there, Martin Stone here from Switch On Health, and thank you for joining us for tonight's free webinar on systemic nickel allergy syndrome. Now, if you're watching this live, please do stick around until the end because you'll have the opportunity to ask questions and have a chat with us. And of course, there will be a $50 voucher to put towards your studies for one lucky attendee. If you are watching this on YouTube, and you like what we see and you want to see more of this kind of content, then please just help us out by clicking on the subscribe button because the more subscribers we have, the more we can offer. And we look forward to offering you more. Also, if you are watching this on YouTube and you do have any comments or questions, you're welcome just to pop them into the comments box below, and we promise we will get back to you. So tonight, I'm very happy to be introducing Jaclyn Ward, who is a Brisbane-based naturopath. Now, Jaclyn has got years of experience both as a practitioner and as an educator. Now, tonight she's going to be presenting on something that I've never even heard of. So I tell you, I've been in the game for, I don't know, 30 years almost. So yeah, look, this is completely new to me. So I'm really looking forward to learning more about this condition. So Jaclyn, thanks so much for coming on tonight, and I shall hand it over to you.
Thank you. Thank you, Martin. Thanks for that introduction and thanks for joining everyone. Um, yeah, look, that's right. Martin probably hasn't heard of it. Many physicians haven't. I have presented this to a bunch of practitioners at an association event. That was last year and it was all new to them. So, systemic nickel allergy syndrome. So I refer to it as SNAS. You're probably going to hear me use that abbreviation a lot in this presentation. It pretty much is an unheard of condition. So now I'll start with, I guess, why. Now, anything that is systemic in nature, as we know, as naturopaths, anything that is very complex and I guess multi-system involved is generally going to be a little bit difficult for Western medicine, as we can imagine. They tend to like to, I guess, take that reductionist view. Now, once I go through, some of the pathophysiology and the symptoms, you'll see why it can be a bit of a, I guess, a problematic condition, at least from a diagnostic perspective. And that's because the symptoms are so broad. But then on the other hand, with CAM practitioners, it can also be a little bit of an issue too. And you'll see why, we can often use, I guess, some scapegoat diagnosis or diagnoses as well. Things that you've heard of like, chronic inflammatory response syndrome, MCAS, mast cell activation syndrome. All these conditions are kind of loose in terms of their criteria, a little vague, and I'm not saying they don't exist. Often they will cross over. Many patients will have some of these or all of these, but often a patient will want a diagnosis and they can easily be put into one of those diagnoses. So it is a very, very complex condition, and this presentation is a very big presentation. So what I've tried to do tonight is I really just want to give you guys a bit of an overview. Okay, now because it's multi-system involved, I'm only going to try and cover maybe some of the gastrointestinal stuff, and what it actually looks like and distinguish between a nickel allergy, which you've probably all heard of in terms of a contact nickel allergy, and how that might differ to a systemic nickel allergy syndrome. So on the agenda, we won't get through all of this. Sorry, I'll click over. Sorry, it's taking a little bit of time to load. Um, but I will take you through some of the pathophysiology briefly, what a contact nickel allergy is, because we need to understand that to get to, I guess, an understanding of the systemic presentation. And I'll take you through some of the GIT manifestations as well. But keep in mind, like I said, it's quite a big topic because typically, I'll usually cover things like the endocrine dysfunction it causes. It often manifests a lot in the endocrine system. Obviously, skin as well, which is a very common manifestation for a systemic nickel allergy. But there's a lot in terms of diagnostics, how to manage a patient with SNAS. I should also mention back to the endocrine, slash repro, some of the common gynecological issues that we see, such as endometriosis. There's a common co-presentation there as well. So um, my aim is to, in clinic mentoring to probably cover a case like this. I think as naturopathic students, it's a really good topic to use to get a greater understanding of those systemic presentations and how it can manifest. So, looking at just the main sources of nickel, we know it's very ubiquitous in the environment. So, we're going to see it in things like, dental materials, very common, jewelry, glasses, patients that are on the tools, so occupational tools. We're going to see it in utensils. So you could see there, on the cover page there was a knife and fork, very common. It's an alloy, so you're going to see it in pretty much all stainless steel products unless it's labeled, and we don't have those labeling laws in Australia. Okay. Europe, we do, it's a known allergen. Surgical implants, that's a whole nother area actually. There's a very good podcast dedicated to patients that are having systemic reactions from surgical implants. Diet, now, nickel's ubiquitous in the diet too. This is why this problem will be our problem when it's known, okay? And that's because of some of the things that we recommend, but we work with diet. So we have the capacity to really help these patients. We also have the capacity to suggest some dietary interventions that are going to well and truly push them over the edge as well. So that's why it's really important to get a good understanding of this condition. And nickel's also going to be naturally in drinking water, and that's going to vary, geographically as well. So you have a lot of geographical differences in terms of, food and water. So this isn't about contact nickel allergy, but I'm just going to give you an insight into contact nickel allergy because it can lead to the systemic response. So nickel allergy is very common, right? So, you get ear piercings, you start to react to your ears, you get, you're on the tools, you start to get a contact dermatitis. Very common, in Europe, it's probably around 20%. Some studies show it might even be a little higher than that. There's a strong, it's obviously, in females, it's more likely. And because of, its ubiquitous nature, it's in everything for those people that are handling things like money, tools, our scissors, like hairdressers that have prolonged exposure, they're going to, at least more likely of developing a hypersensitivity because of that constant contact. Now, the most common reaction is a allergic contact dermatitis, right? So that's when you touch it, you can develop a contact dermatitis. But nickel can also manifest without direct contact to the skin. Okay, so there's three things I need to take you through. Contact nickel allergy, which is pretty easy to understand. The next one is systemic contact dermatitis. Okay, so what happens just generally with nickel allergy is the metals, they can penetrate the skin barrier and they reach the epidermis and the dermis. Then the antigen presenting cells process the nickel protein complex and they present it to T cells. These T cells then become sensitized to nickel, right? And then the patient is re-exposed. And so upon re-exposure, those sensitized T cells are activated, releases inflammatory mediators, and it causes that, typical kind of rash. Okay, so that's allergic contact dermatitis. It is a type 4 contact allergy, right? So it's not like your IgE driven allergy where it's immediate, it's a type 4. So it might show up some hours later to even some days. Okay, so we understand contact nickel allergy. The next thing to understand is systemic nickel dermatitis, or nickel, it's sometimes referred to as SCD, systemic contact dermatitis. Okay, so this is a little bit tricky, right? It's well established in the dermatology literature, though. I've found most of the research, at least on STD and the more systemic contact nickel allergy syndrome, Europe and the US really lead the research, particularly Southern Europe, so Italy and those countries. Systemic contact dermatitis, there are some dermatologists that will test for it and recognize it, but you'll be surprised how often this is missed. Okay, in the literature, it's very odd that patients aren't usually suspected and then the suspicion is confirmed. Unfortunately, that doesn't happen. So with systemic contact dermatitis, this is caused by the ingestion of nickel, right? So it can be through cooking utensils, through the use of stainless steel coffee cups. Like I said, cooking in stainless steel pots. The biggest contributor is food, typically with these patients, right? And what happens is similar pathophysiology, it's T cell mediated. They become sensitized. And what happens is with the ingestion of nickel, they start to have an eczema manifestation. And that's usually typically seen on the eyelids, the neck, the inner thighs. It is, I guess, a classical manifestation is a vesicular hand dermatitis, right? So you may have heard of dyshydrotic eczema. That's one vesicular hand dermatitis where they get itchy little bubbles that appear on the hands and the feet. That's a classic systemic contact dermatitis. I should say nickel systemic contact dermatitis presentation. There are others as well. So nummular eczema, even anogenital eczema, vulvodynia, and vulvar dermatitis is also a common complaint in systemic contact dermatitis patients. So what happens is it's caused by the sensitization of nickel, but it's also independent of metal handling. Okay, so what is thought to happen is that these patients at some point in their life did have a contact exposure, a heavy contact exposure. The T cells were sensitized, and then in addition to the high ingestion of nickel foods or substances with nickel in it, it causes this T cell reaction and, as a consequence, a skin manifestation. Okay, so we've covered the contact allergy. We've covered systemic contact dermatitis, systemic nickel allergy syndrome, which is what I'm talking about. This is a different thing, right? This is usually the systemic contact dermatitis, but there's extracutaneous symptoms with this syndrome. Okay, it's very, very broad. These are some symptoms here. It's not all of the symptoms. Okay, so you can see here on the left-hand side, the SCD. I've just mentioned that, systemic contact dermatitis. This is part of the larger SNAS presentation, right? And the skin issues are not just eczema, not just dyshydrotic eczema. They've been linked to things like urticaria, which we would typically think is an IgE-driven condition, but not always in this case. Some good research on it. There's lots of other skin presentations. Even rosacea is very strongly linked to a systemic nickel response as well. Baboon syndrome, maculopapular eczema, flexural eczema, urticaria, anogenital eczema. So the list goes on. Right, so we've got that, we understand that. Now the extracutaneous symptoms. So that's symptoms that are not skin related. Probably one of the most common is the gastrointestinal manifestations of this condition. Okay, so that's really what I'm going to take you through today. There's a lot of others. So like I said, the endocrine system is heavily implicated in here. The incidence of thyroid conditions, endometriosis, other autoimmune and idiopathic autoimmune conditions, respiratory conditions. So we won't have time to go through that today, but just a quick mention. All right. Now, the neurological symptoms, it's not just headache. There's a whole list of symptoms as well. Things like brain fog is very common, sensitivity to sunlight. It does cross over with mast cell activation syndrome too. So you'll often see that sometimes patients will be put into that category. And then later they have a diagnosis of systemic nickel allergy syndrome. They've realized that majority of those issues were nickel related. I'm not saying that that's with all patients, but what I'm saying is it can easily be a scapegoat diagnosis. All right, I won't spend too long on the pathophys, but what I want to make clear is this is not a toxicity, right? We often hear about metal toxicities. This isn't a toxicity. Now, there's probably some level of brief toxicity because of the way it's metabolized, nickel, but it is an allergy. So these patients are just unfortunate and they cannot handle the same amount of nickel in their diet as a patient that isn't sensitive. So I need to make that clear. It's not a toxicity. This is a type 4 allergy. Okay, so all right, so I'm just going to move this out the way so I can see. All right, so it is an emergent chronic inflammatory disorder. Okay, it's relatively new. Systemic contact dermatitis isn't, but SNAS is a relatively new condition. Now, it occurs in roughly, they say 20% of patients with delayed allergy to nickel sulfate. So that's the contact allergy. Those patients that have a contact allergy, there's a small percentage of those patients that will go on to develop SNAS. Okay. And as when I say SNAS, that's the extracutaneous symptoms, respiratory, gastrointestinal, endocrine, neurological. Okay. As a result of that high dietary nickel. Now, it's a type 4 sensitivity. So remember, that's not immediate, that's not IgE driven. And what happens here is that the nickel acts as a hapten. So it binds to the skin proteins and it forms this antigen complex, right? That's recognized by the immune system. And this complex is presented to those antigen presenting cells, to the T cells, and that leads to this delayed hypersensitivity reaction. So the pathophys of this condition involves T helper cells, so Th1 and Th2. And in that initial phase, it's called the induction phase, that's where the presentation of nickel antigens to the T cells happens. That causes that sensitization, right? And then, upon re-exposure, those prime T cells basically think, all right, let's go to war. And it's not just limited to the skin. Remember, those T cells will infiltrate into other areas, gastrointestinal, etc. TLR4 is also involved in this as well. It also influences that allergic sensitization as well. And that's part of, TLR4 is part of a, different part of the immune system as well. So you've got the innate and the adaptive involved here. All right. So basically, they re-exposure, the T cells like we're going to war, and what can happen is that these T cells stay primed and they can stay primed for months, right? If the intake of nickel is constant and consistent, I like to use the bucket analogy. Their nickel bucket keeps getting, bigger and bigger. It's filling up, and their T cells are hyperactive. They need to diminish that bucket, and over months, usually about 3 months in the literature, the T cells realize, all right, we can calm down now. We're not at war anymore. Okay, so just want to make that clear that it's not really a toxicity. Okay, there is to some degree there might be an accumulation. Nickel does seem to have an affinity for the endocrine tissues. On biopsy we do see it in breast tissue. We see it in the thyroid. Interestingly, we see it where estrogen is too. Right? I'll come to that maybe not today, but some other point because there's a very very interesting relationship between estrogen and nickel. So there is some cross reactivity too. So we do see that patients that do have IgE-driven allergies also are at risk. So there's probably some shared pathway, immune pathways happening there. But just in summary, there is quite a complex interplay between the exposure, the immune sensitization, and then the systemic inflammatory responses that are triggered by this ingestion of nickel in susceptible individuals. So that's just a nice little summary, really, of what I've mentioned there. In short, I probably should have just jumped to there. All right, there's a number of genetic and environmental factors as well to consider. Possibly some HLA genes as well, genetic factors there. HLA, that subset of genes is involved in, things like thyroid autoimmunity and things. So there's a potential that those patients might be more susceptible, but there's a lot of environmental exposures as well, geographically, where the patient lives, what they're exposed to in terms of soils, volcanic soil. Also, are they eating locally? Are they eating seasonally? Are they eating foods that are are they eating cocoa from Brazil every night? These things are very relevant to these patients, okay? Now, just to give you an idea of the complexity of this condition, this was a comment from a patient. She said, before diagnosis, I saw an endocrinologist, a dermatologist, a gastroenterologist, an immunologist, a gynecologist, a neurologist, because of all the issues I had. Okay. And she had finally a diagnosis of systemic nickel allergy syndrome. Okay, so this is the problem. You can see why in Western medicine they don't like this stuff. There's too much of a multi-system involvement, right? So, whose problem is it? Is it the gastros? Is it the immunologist? In Australia, really, because we don't have any understanding of SNAS, it usually gets referred to a dermatologist, right? Now, I'm not going to go through the diagnostics today, but I will mention that there's several ways to diagnose this, and this deserves probably a very thorough discussion because there's pros and cons and there's limitations to each. But for contact nickel allergy, the gold standard is a patch test. Okay, not many dermatologists do patch testing in Australia. There's one or two in Queensland that do it, an immunologist group I know of and a professor of dermatology, but it's not standard practice. Okay, so now that diagnoses a contact allergy. So, and it's very important to distinguish between a RAS test, a scratch test, which is IgE, and a type 4 contact allergy test. They're very different, right? A type 4 contact allergy test requires patches on the back for 5 days. So they're put on and then they're 48 hours, they'll take them off and they'll look at the response from the allergen. And then another 48 hours later, they'll check and do a final reading. Some countries, they'll do that 7 days later. So that will diagnose a contact allergy. But some skilled dermatologists will be able to take that information and trial a low nickel diet. Often, if it's a very aggressive lesion, they'll say, yep, no, this is systemic. You need to trial a low nickel diet for 3 months and you need to see how you go. Okay. In other countries, there's um, diagnostics that are fairly new, but seem to be better in terms of their ability to diagnose a systemic manifestation, right? So, not just contact, to diagnose gastrointestinal manifestations, endometriosis and those kind of co-presenting conditions. So I just want to mention that there's also an LTT test, which is done for patients that have metal sensitivity as a result of implants. And there's an oral nickel challenge test, right? There's quite a big conversation with diagnostics, though, and what the patient might suit and what kind of data you can take from those diagnostics as well. All right, so I'm going to go through a little bit of the research on nickel and the GIT because, we're natural health physicians. I thought this is probably very relevant to us. So is all the stuff, and it's very good to get a full understanding. But because of time constraints, I'm going to start with nickel and the GIT because it seems to be a very, very big issue with many patients. And I think what's interesting is we now have, I should say as well, there's a private Facebook page that was started by a Canadian lady, Systemic Nickel Allergy Group, and we've got 7,000 patients on that page, and I do some, expert administration stuff there. So we get some good data from that page, and I must say that there are patients now that have very little skin manifestations, right? So they have major gastrointestinal symptoms, very little skin manifestations. So it doesn't always mean that they will have a very, very strong skin presentation. So keep that in mind. That's what the dermatologists want to see. They don't have a chronic hand eczema. They might not be interested in patch testing these patients. So there's some challenges here. All right, so nickel in the gut. In Southern Europe, the specialist that actually diagnoses a systemic nickel allergy is a gastroenterologist. Okay, so patients that have a systemic nickel allergy, they will have changes in the gastric mucosa. The symptoms that they usually will experience are recurrent mouth ulcers, and typically it's an IBS, as you can see, abdominal bloating, distension, recurrent pain, diarrhea, constipation, nausea, vomiting. Eventually, on endoscopy, when they do an endoscopy, their findings will generally conclude that there's chronic gastroduodenitis, and there's also other atypical systemic clinical manifestations that go hand in hand with what they're experiencing gastrointestinally. Okay. So things like cystitis, shortness of breath, generally things like iron deficiency anemia, vaginitis, acne, plus all the other skin issues generally, as I mentioned before. So that was in one study what the researchers listed. Now, the next slide here, this gives you a clinical overlap between IBS and IBS-like disorders. So you'll see here, we've got IBS in the middle. Then this one here is nickel allergic contact mucositis. So this is basically the nickel IBS. It's referred to as nickel allergic contact mucositis. Okay. So this is really, I guess it isn't, but it should be considered another DD when it comes to IBS like disorders. So we've got celiac disease, we've got SIBO, we've got IBS, we've got FODMAPs, lactose intolerance. All these patients with nickel allergy can have any of these, and often all of these are co-presenting. This is non-celiac gluten disease, all right, or syndrome, I should say. All right, so there's a big overlap, and I'll get to that because the research on the FODMAPs issue is very interesting. Okay, so as I mentioned, nickel allergic contact mucositis is basically the delayed hypersensitivity reaction in the gut that typically equates to an IBS-like issue. So it's, causes quite a severe gastrointestinal inflammation and all those associated symptoms when the ingestion of nickel happens. So this is just a very brief summary of IBS and SNAS. So in 2016, there was a pilot study that found that a low nickel diet improved GIT symptoms in patients with IBS and SNAS. So the study included 20 IBS patients. They had a suspected SNAS, and they showed a significant improvement in symptoms after 3 months on a low nickel diet. In a 2019 case control study, so it's fairly recent, it also demonstrated a high incidence of nickel hypersensitivity in IBS patients, and that was compared to healthy controls. So they found 56.5% of IBS patients were hypersensitive to at least one metal, including nickel, and that was compared to 31% of controls. And in a 2022 study, they investigated nickel sensitivity in IBS patients using patch testing, and they found nickel sensitivity in 40% of IBS patients compared to 17.5% of controls. So this suggests a significantly higher prevalence in IBS. And there was a case report fairly recently of a patient that had SNAS, and he had a diarrhea predominant IBS presentation, and his symptoms improved with nickel restriction and probiotics. And that just highlights that potential connection between the nickel allergy and intake of nickel, IBS, and the gut microbiota. So I've got quite a bit of data on the gut, on the microbiome and nickel, but I haven't included it in today because we'll be short on time, but it is there, some good research. All right, excuse me for 1 second. Okay, so moving on to the overlap between FODMAP-rich and nickel-rich foods. So is it SIBO or is it dietary nickel? So you'll see here, and I should mention too, SNAS patients that have been tested for lactose intolerant, 85 around about, might have been 86% of them are lactose intolerant. Okay, so that's a big issue. Okay, so these patients here, so you've got your high nickel foods, right? And this requires a big discussion because foods geographically they're going to differ, but we've generally got groups that are going to be, groups of food or food groups, I should say, that are going to be naturally high in nickel, and then you're going to have some geographical variation of other things, right? So generally we try and keep those patients on the lower nickel food groups, right? Then we've got your high FODMAP rich food. So you can see here, there's actually a very big overlap. So it's therefore possible that, during a low FODMAP diet, other underlying conditions such as a systemic nickel allergy could potentially be treated, or generally if the patient improves but not completely resolves and they have other co-presenting symptoms such as skin manifestations, some thyroid involvement, perhaps endometriosis, that could be a red flag that perhaps nickel allergy or systemic nickel allergy is a potential issue. So they go on a low FODMAP diet, and they improve and it's not quite enough, there could be other things there. Are they cooking in nickel pots? Yes, they probably are. Are they drinking from, reusable stainless steel coffee cups? What other things or what other sources of nickel could they potentially be getting through their diet and lifestyle? So the other issue as well is that nickel intake influences the gut um, microbiome as well. So it can contribute to dysbiosis, right? And we know SIBO is a dysbiosis condition and it's generally secondary, right? It's not a diagnosis as such. Well, it is, but there's usually generally a cause of SIBO. There's a root cause. So again, is it nickel causing some dysmotility? All right, moving on to this study. Nickel allergic contact mucositis in suspected non-responsive celiac disease, a pilot study. Now, this study was fairly recent. It was done in 2020. It's an interesting one. Now, usually, a patient's diagnosed with celiacs, they're put onto a very strict gluten-free diet. What happened with these patients is they got a bunch of patients. Now they had a resurgence of these gastrointestinal symptoms, right? So they were diagnosed with celiacs. They went on the gluten-free diet. They were very strict, but for some reason their symptoms either returned or they still had no improvement, right? Now, the gastroenterologist doing this study had to make sure that in terms of their histology and the serology, that looked perfect. They're celiac patients, but they can tell that they've been on a celiac diet. So they therefore really should investigate, well, what else could be going on with these patients? Is it IBS-like disorders? Is it IBD? Is it Helicobacter? What is it? So they got all these patients together and they decided to look at the prevalence of nickel allergic contact mucositis, which remember is that IBS manifestation of SNAS. So they got all these patients together and they had to go through all their, inclusion, exclusion criteria. They had to make sure that they were in, serological and histological remission, but they had those relapsing symptoms. And so what they did was they went through all their criteria. A whole bunch of patients got removed, unfortunately, because some of them didn't have the criteria. They didn't have three or more symptoms. 85 patients were excluded because 85 were excluded because a bunch of them were lactose intolerant, which gives us some clues. Perhaps they were SNAS patients given the high percentage of lactose intolerance, but they weren't allowed in the study because they believed that the lactose intolerance was the cause of their resurgence of gastrointestinal issues. Some had Helicobacter, some had, ulcerative colitis, and three dropped out from the remaining 23. So after all that, there were 20 patients left, okay? 20 patients that had this, still debilitating symptoms despite a celiac diagnosis and maintaining a no gluten diet. They're all female. Now, what they did was this is a very sensitive test. We don't have it in Australia. I've emailed professors of dermatology and gastroenterology and oral pathologists, but it's called a nickel oral mucosal patch test, and they very sensitive test. They use it to diagnose the gastrointestinal manifestations of SNAS. They put a little nickel disc into the under the lip. They leave it there for 2 hours, and they assess that using a particular tool 2 hours later, and that gives a diagnosis of nickel ACM. So anyway, they did that to these 20 patients that were remaining in the study, and 100% of them had a positive result. Okay, so they all showed evidence of local mucosal alterations induced by nickel. And that was after 2 hours of the patch was applied. And interestingly, all 20 patients as well showed at least one additional gastrointestinal or extraintestinal symptom or systemic symptom. So they showed either something within the gut or a symptom that was not gut related, like, a skin manifestation that flared, right? Just from the patch test, which often happens when you do it on the back too. So what happened? They put them on the low nickel diet plus a gluten-free diet. And in 3 months, it improved. There was induced an improvement of more than 80% of the symptoms. And in the half of the cases, the improvement was statistically significant, including the most complained about symptoms, which were the IBS-like symptoms. So the study found that for the first time, nickel-rich foods and nickel allergic contact mucositis can frequently be the cause of relapsing GIT and extraintestinal, so symptoms outside of the GIT in celiac disease patients, okay, even or especially during a correct gluten-free diet. Gluten-free diets can be quite high in nickel. All right, so that's really interesting, isn't it? I think we need to know about this, right? We are, let's say we're gut specialists. We tend to think of ourselves like that. This is a differential diagnosis that is largely unheard of. So um, it doesn't stop there. There's lots more stuff on, IBD and etc. There's a little bit here I've mentioned here too. Some of the other more oral manifestations that we can often see in these patients. One big issue is braces. I always ask patients about dental work. Braces, there's some interesting research on braces. When ear piercing when braces are given before ear piercing, they seem to be less sensitive. But braces after ear piercing, so let's say braces in the teen years and ear piercing in the very early years, this seems to be a risk factor. Now, I'm not saying it's the only factor, but it is a question to ask, especially if you have adult patients that have perioral dermatitis, they have chronic angular cheilitis, which, we often think it's a B2 deficiency or it's a dysbiosis. It can be a dysbiosis because nickel that's present in the oral mucosa will create a dysbiotic environment. But this can also be a type 4 allergy, right? Especially if it's co-presenting with things like chronic mouth ulcers, ulceration, burning mouth syndrome, um, mouth sensitivity. These can be very clear signs of a systemic nickel allergy syndrome, right? So when they've been sensitized, either they had braces, they might still have a metal retainer, or they might not have anything, but they had them years ago and could just be a high nickel diet that will promote a relapse. Okay, so always a good question to ask for these patients. Tell me about your dental history. All right. I probably could have went a little bit longer, but I might open it up for questions soon. But I just want to get to, I guess, now that you can see, there's quite a significant gastrointestinal manifestation in this condition. Um, why should systemic nickel allergy syndrome be on our radar? Now, for one reason, it might be an underlying factor in our patient's chronic treatment resistant illness. Okay, so I haven't gone through everything here. Like I said, there's a lot of literature to go through on urticaria, on rosacea, on the different diagnostics, on the very strong connection with endometriosis and other estrogen issues. So if you have a patient that has all these conditions and also looks like they have a fairly heavy estrogen issue, that should be a red flag. Um, Also, the thyroid as well. There's a lot of good evidence that it increases the risk of thyroid autoimmunity. SNAS patients have a higher risk of nodule formation and CAT, so chronic autoimmune thyroiditis, is very, very common in these patients. I probably last year I put out a bit of a survey on the private SNAS patient group, and I think within about 45 minutes I had 70 patients comment yes, they have either thyroid removed, partial thyroidectomy, on T4, no nodule, thyroiditis. So very, very common presentation. Okay. Then we've got all the dietary considerations, and that requires quite an intense discussion in terms of the management of the diet, because what can happen is, and it brings me down to this point here, as holistic and integrative health professionals, we have the capacity to do great harm, unfortunately, if it's not on our radar. And that's by some of the things we recommend. Our typical kind of whole grain, high bean diet, it's not going to work for these guys. It's going to actually put them into a highly inflamed state. So this needs to be on our radar. One, because we spend a lot of time with patients. We can join the dots. We understand generally the connection between the organ systems, and we can give good counsel, dietary counseling as well. This point here, consideration of systemic presentations of nickel allergy as a possible differential diagnosis in chronic disease. So, if we look at some of the conditions that we see in clinic these days, I mean, 30, 40 years ago, if we speak to some of the naturopaths or CAM practitioners, they probably weren't seeing the things we see now, and that makes sense given what we're exposed to. We're often seeing patients that would probably be labeled as a, mast cell activated syndrome patient or a KERS patient. So chronic inflammatory response syndrome, which we've got a lot of environmental factors there with chemical sensitivity, mold biotoxins. Then we've got stealth infections, like your Lyme-like infections. We've got idiopathic autoimmunity as well. So things like, your autoimmune joint issues. Nickel allergy, I should say, SNAS is highly implicated in those conditions like fibromyalgia as well. So these kind of idiopathic presentations, or I should say autoimmune presentations, we need to have nickel or SNAS, I should say, there as a DD, I think. Not suggesting it's everyone has it, but so we can recognize the symptoms and the systemic manifestations and go through that process of, is it a possibility for the patient sitting in front of us? Now, the last point here, management requires dietary and lifestyle changes. Now, there are a lot of lifestyle changes, a lot of dietary changes. It's not as simple. It does require some counseling. A patient that's drinking a cup of coffee a day, if they're getting coffee beans from Ethiopia instead of coffee beans from South America, there's a big difference in nickel content there. Something as small as that could tip these patients over the edge. If they're cooking in a stainless steel pot, most stainless steel is 10% nickel. If it's not labeled and they don't know, they're going to absorb that nickel from the pot. Okay, so you've got diet, then you've got lifestyle, right? I've had a patient that, had a stainless steel Yeti cup. That was enough and that's hot coffee, right? Enough to push that patient over the edge. Okay, so it does require a lot of counsel for these patients, and there's no practitioner that is currently doing that. Okay. Um, so we have the capacity to get these patients into a state of remission and symptom management, right? These allergies, they don't go, they get worse at certain times of during the life. And I might 720, so I might just talk about that as well. Um, one, I think one red flag is if you have a female that's had a exacerbation of these issues postpartum. Often it does rear its head in those kind of hormonal transition states, right? Things like SNAS will generally improve in stages like pregnancy. Some will say it's estrogen. I think estrogen is actually a very annoying factor. It's progesterone, right? It stabilizes mast cells, it regulates the immune system, and then once the baby's birthed and the placenta's birthed, goodbye progesterone and hello, autoimmunity again. So that is a red flag as well. I've had some new mums that have all of a sudden broken out in a hand dermatitis plus systemic symptoms. That's a red flag. So then there's other stages where they might get an exacerbation, cyclically, where histamine might be a greater issue, such as a luteal stage. So there's a lot of clinical clues as well with SNAS. Um, Another few things, I guess, that I might mention, and then I might open it up for a few questions. I think when it comes to these cases, and I think SNAS has taught me a lot about being a clinician, being in practice for, well, a decade and a half now. When we're students and, in I guess, the early days of practice, we're really drummed in those core naturopathic philosophies, right? So, you know, eat locally, um, get sunlight, all those kind of things, they are actually very, very relevant to these cases. Very, very relevant. So, I also think that when we learn, about the Western medicine understanding of autoimmune, we kind of, we have to understand it from their perspective. But when you see these things in clinic, you realize that no, the body's not turning against itself. It's far more intelligent, right? These are warning signs. So I think that's really important when it comes to these cases, because often these patients that come to see you, they have every symptom, every system's involved, and they're pretty much over it, right? And they're sitting in front of you, and what you need to do is you actually need to focus on those very, very basic things because they actually make all the difference. Okay. So eating seasonally for these patients is actually really important. Sure, there's more to it, but like I said, if they're getting foods that are, like acai berry and coffee and chickpeas and tomatoes from Italy, which all the canned tomatoes are, and they're getting cocoa from Brazil, this is going to tip those patients over the edge. The other thing is, as well, these patients really need to go back to basics. So that whole dark and light cycle, circadian biology, all these things are really, really important because I think at the core of these chronic inflammatory conditions is that they are extremely complex, but there's something happening at the cellular level. Okay. So either there's a cell membrane issue, there's a redox issue, there's something beyond chemistry that's happening as well. There's the biophysics involved here, there's the whole light dark cycle. And I'm not just saying sunlight is involved, and this is probably more theoretical, but their exposure to natural UVs, their exposure to the cycles that really govern human biology, which is light and dark cycles, their exposure to synthetic light, their exposure to natural light. These are all very relevant from a cellular dynamic perspective. So I think that if we even start to use SNAS as a diagnosis, then we become guilty of those practices that are solely focusing on other things like histamine intolerance and MCAS. They all probably do share a very similar root cause, and those core naturopathic principles to reestablish um, homeostasis are really, really crucial. Okay. And also understanding what kind of, I guess, hormetic influences we should talk to these patients about, right? If they live in the Northern Hemisphere, which is very prevalent there, they might need to use cold, exposure. If they're, living in, more equatorial, which doesn't seem to happen there, there's very little SNUDS patients, which is very interesting, but, they have access to more sunlight and things like that. So that's more theoretical, but it definitely fits in with the, I guess, the biophysics at the cellular level with chronic and systemic disease presentations. So I'll leave it at that because it's a very big topic. Um, and at some stage, for those students that might decide to do the clinic mentoring program, I'd probably like to go through this and using a good case example because I think it's a great condition to be able to demonstrate what a chronic case looks like in clinic as well. And it gives you the opportunity to go through a lot of different conditions and looking at it from a little bit more of a holistic perspective, right? So I'll leave it there, but are there any questions? I probably would have covered this in the longer presentation, but please let me know if there's anything I can answer now or, point you in the right direction.
Fantastic. Thanks, Jaclyn. Yeah, look, we'll definitely open it up for questions for everybody in a moment. We'll stop the recording before we do. I guess, I'll just chuck in a couple of questions first of all
Sure.
to sort of tie things off. Um, I mean, look, first of all, I've got to say, I'm just counting my blessings here. I'm so grateful that I don't have this. So far as I know, I don't have it.
Yeah,
Um,
it's better to have celiacs than this, I think. No disrespect to our
you know,
celiac patients.
it sounds like for some people, it just sounds like it's terrible. Yeah. And they could go on this journey for years and years and years, and they might get some help with somebody thinking, oh, it's, we'll treat you for this, we treat you for that, we treat you for the other, and you might get some results, but, ultimately they're not really getting to the cause of what is driving this in the first place. And then, if somebody's lucky enough to even figure out this is what it actually is, well, then
That's
managing
right.
that is a whole other challenge in itself as well. And that takes a lot of work. So,
That's right.
yeah, what a short straw to draw,
Yes,
really.
that's right. Exactly. Even getting to the point of a diagnosis or someone even flagging it, it is, you're right, Martin. It's very unlikely. So,
Yeah,
hence why I'm trying to raise awareness. I think it's probably going to be something that's going to come back on us, I think, given,
yeah,
the lengths we go to in our consultation process. So, if the CAM community has a good understanding of it, we're more likely to be able to flag it as a potential DD.
yeah. Now, you might have covered this at some point, but I guess this is a bit of a sort of how long is a piece of string question.
Mm, mm.
Um, but let's say, somebody comes to you, um, at what point would you think, you know, it's definitely worth investigating
Investigating.
this?
Yep. Yep.
And up to, like, how would you actually,
Yep.
where would you go for further testing?
Yep. Yep. Good question. And I do go through this in the longer presentation, but to give you, I guess, a very short answer, this is where it comes down to clinical questioning. So there's a few key questions that you want to ask. Firstly, if it's a very classical presentation, so if there is a skin manifestation, is it on the hand? So any patient that has a hand eczema, they should be investigated for a contact nickel allergy, right? That would qualify. Now, there is a dermatologist that he will nickel test if that's the case, if there is a clear contact allergy, or not a contact, but some kind of dyshydrotic eczema presentation, either on their hands or the feet, or there seems to be what looks like a contact allergy. Okay, so those patients, I would get their GP to refer, but for me, I want to see other presentation. So I want to see gastrointestinal manifestations. I'm going to ask a history about, all right, have they had any surgeries? Is there any staples? Do they have any hardware that's left in? Do they have any thyroid pathologies? Is there antibodies that are raised? I'll get a good understanding of their diet, how they're reacting to certain foods like nuts and seeds. Are they prevalent in their diet? Are they reacting to FODMAP foods? Is there any oral manifestations? So I'll go through quite a thorough questioning to see, all right, is it is this a potential issue? And if there is a clear skin manifestation, what I'll do is I'll get them to get a referral for a contact allergy patch test. Okay, so there's only a couple of specialists that do that. It's not a routine dermatologist thing, which is very unfortunate. It is their scope, but there's only one I know of and an immunologist. There are some clinics, allergy clinics, that will do it, but they're not done by European standards. So that's something else to consider in that discussion around diagnostics. So that's typically what you do. But there's also the possibility for, a naturopath or nutritionist or CAM practitioner think, well, all right, this patient has potentially looking like this is a very likely DD. What about if we consider a low nickel diet and lifestyle for 3 to 4 months and see if there's any improvement, right? And generally, if there is, and there's a significant improvement, the chances are that it probably is that. And as a matter of fact, prior to the oral mucosal patch test in Europe, that's what the dermatologists will do. They'll actually put them on a low nickel diet, then they will patch test them. Then they'll give an oral challenge test to elicit the symptoms again, to confirm the diagnosis. So, there's no issue doing that. We have the capacity to formulate a very nutritious diet because they can do this diet. It can be an awful diet or it could be a very whole foods, good quality diet. It's just a little bit challenging to do it as a vegetarian diet. So I will say that.
Thanks. That
So,
was excellent answer. Thanks, Jaclyn. I would say though that let's supposing we put somebody on a low nickel diet for 3 to 4 months, chances are we're going to be like cleaning up their act and
That's
the
right.
diet's going to be better than it was before anyway. So you probably would see symptom improvement, even if
That's
it
right.
wasn't nickel that was the driver. Yeah.
That's right. That's
Um,
right. But you also got to keep in mind you are getting them to exclude a lot of so-called healthy foods, right? So a lot, whole grains, nuts and seeds, beans, right? So like I said, they could actually have improvement on a highly inflammatory white beige food diet, possibly, right? And we don't want that because we're about reducing systemic inflammation. Fine, we could get nickel symptoms down, but we want to actually improve them. We want to, bring back a state of homeostasis and correct things. So that's where the dietary intervention is very interesting, but they certainly can get improvement on a very, not so nutritious low nickel diet.
awesome. Thanks, Jacqueline. Okay, I've got one last question before we stop
Yeah.
the recording and open it up. What took you down this path? How did
Yeah.
you end up?
Well, there's a little bit of a wounded healer story in this because after about 20 years, I thought, I think I have this after my first child, of course, which is very typical. And we see this in clinic with a lot of autoimmune, patients will get better when they're pregnant. They have a nice surge of progesterone, and then all of a sudden, in that postpartum period when progesterone's typically low, their symptoms will be 10 times worse. So I suspected this and went to my colleague, and I had it confirmed. And I had already been working with very kind of, I guess, chronic presentations, gastrointestinal presentations, thyroid, very systemic, chronic systemic patients that would typically present with these kind of things. So autoimmunity was always a bit of a personal interest for me. So then when I really looked into this, so, I decided, after this to go on a bit of a self-directed education journey. There was no one really looking at this in Australia. I connected with some health professionals that gave me some understanding, but I thought, no, there's something more here, and I think we need to know about it. And so the last, 5 or so years, I've been focusing on this, and since then, I've flagged it in a bunch of patients in clinic. But Martin, I'd hate to know how many I've missed too. So that does dawn on me, how many I've missed, in the 10 or so years of not knowing about this condition as well. So, but better late than never.
Look, that's a great place to wrap it up. Thanks, Jacqueline. I think it really goes to show that the learning never stops.
That's right.
Like we've got a bunch of people here who are probably in their first year of naturopathy, and their heads are probably spinning. We've
Yeah.
got one of our graduates is here tonight as well, and yeah, obviously the learning
Oh, great.
never stops, does it? Yeah.
Yeah.
So look,
Yeah.
Jacqueline, thanks so much. That was
No,
an absolutely awesome presentation, and
thank
I'm
you.
sure everybody can tell we're just scratching the surface here. So
Yeah.
there's a lot more to come. So look, if you are watching this live, stick around. I can see we've got some great questions coming up in the chat, which we will get to. And if you are watching the recording, thank you so much. Well done for making it all the way to the end, and learn more with Switch on Health.